This is John Gever for MedPage Today. Eli Lilly and Company is seeking FDA approval for a depot formulation of Olanzapine, Zyprexa, in schizophrenia for both acute and maintenance treatment. The FDA's Psychopharmacologic Drugs Advisory Committee met yesterday to consider the application. Two of Lilly's academic collaborators told the committee why the depot drug is important. Dr. John Kane of Zucker Hillside Hospital in New York highlighted the issue of non-adherence to oral medication.
So if we look at the data, over 40% of patients with schizophrenia have significant problems with adherence. Many will cycle in and out of adherence. At my own hospital, we've surveyed, it's a 230-bed hospital, we've surveyed the reasons for readmission to the hospital. Half the time, it's non-adherence.
Dr. John Lauriello of the University of New Mexico also stressed the issue.
I really do feel strongly that the idea of being able to know exactly whether patients are taking the medication you prescribe is a very important benefit both to the clinician and to the patient.
FDA and Lilly officials presented a lot of data that indicate a depot olanzapine has the same efficacy and safety profile as the current oral form, with one major exception. That is, uncommon but serious and unpredictable episodes of what FDA has called excessive sedation events. With these, about 1% of patients at some point during therapy, maybe the first injection, maybe the 40th, had a reaction not seen with the oral drug or other depot antipsychotics. Here's Lilly's medical director, Dr. Sara, describing the syndrome.
Patients who have had these events have experienced symptoms such as sedation, delirium, confusion, ataxia, dysarthria, and fluctuations in consciousness. These symptoms began more mildly and often gradually progressed in severity. 5 patients were described as being unconscious or experiencing loss of consciousness. 3 of those patients were reported as having been unarousable for a period of time, one of whom was reported to be in a coma, and another of whom exhibited symptoms consistent with coma.
All patients recovered fully, and most stayed on the drug. Dr. Corya said that the company believes that somehow during the injections preceding these episodes, the depot drug came into contact with the patient's blood.
We do think it's important to explain why we believe that contact with blood is the mechanism. First, the clinical presentation of the excessive sedation events has been very consistent with a rapid rise in olanzapine concentration. And the progression of the symptoms over minutes to hours is consistent with the indirect premature entrance of OP depot into the bloodstream that I just described, as well as the rate of dissolution of OP depot in blood, which, while much faster than in muscle, still requires time. Olanzapine concentrations have been measured in 7 of the excessive sedation events, and in each case were elevated. The lack of correlation of those levels with the doses injected suggests that only a portion of the dose is entering the vasculature prematurely. Again, this would be consistent with our belief about vascular injury and seepage into the vessel. In vitro PK and solubility experiments were conducted, showing that OP depot is indeed much more soluble in blood and plasma than in muscle tissue. Finally, inadvertent intravascular injection is a known risk with IM injections. The IM product that has been most studied in this area is penicillin G procaine, a long-acting formulation of penicillin. And the rate of inadvertent intravascular injection with that product is very consistent with the rate of excessive sedation events that we've seen with OP depot, suggesting fundamentally similar issues with needles and human anatomy.
Nevertheless, the syndrome remains mysterious. Lilly would focus risk management on making sure that patients having these events don't suffer permanent injury.
We believe that OP depot is a critically important medication option for patients with schizophrenia. So we want to find the best way to ensure access to those patients while addressing the also critically important safety considerations.
The company has proposed that depot olanzapine's label require a 3-hour observation period after dosing, as well as patient and clinician education on the sedation events. Committee members talked at length about how to balance this unusual and serious risk with the benefits offered by the depot version. Here is what Dr. Barbara Wells of the University of Mississippi said.
This dosage form does have quite a bit to offer. I do believe that there are large numbers of patients who would significantly benefit from having drug available to them. So I think we need to give a lot of thought to managing the risks and what needs to be done to be sure that the risks are minimized.
Dr. John Mann of the New York Psychiatric Institute said the risks were acceptable for patients with well-established schizophrenia, but he worried that they would not be the only ones exposed to the drug.
It seems to me that there's a very specific and relatively narrow clinical target that one is directing the use of this medication to. But I think that there is probably an additional labeling requirement for these kinds of medications, given the dialogue that has gone on in the greater community, and that is, I think there should be some language saying that trying to address potential off-label uses that come to mind readily. For example, one could see the convenience of this sort of medication in nursing homes, where there is already a concern about the use of atypical antipsychotics to keep people calm and out of trouble, and make life easier on the staff and a lot of things like that. So giving a shot once every 2 weeks to somebody who's a bit out of line, it could be tempting. And I think that in trying to guide the clinician into it so that there are little more so that the medication used does target the real population that's being expected to be receiving this medication. Some additional language like that should also be introduced.
After more than 2 hours of discussion, the committee agreed with no dissenting votes that depot olanzapine is effective and that FDA could clearly identify circumstances in which it would be acceptably safe. Dr. Barbara Geller of Washington University in St. Louis summed up the sense of the committee.
I'm very reluctant to say that we would not take advantage of a new type of drug. And I would consider most of the things I've heard that would say maybe there are some very serious concerns are things that perhaps we can address in question 2 in terms of labeling and second line and black box and questions like that.
I'm John Gever, MedPage Today.